Hello and welcome to our webinar, Why IT and Clinical Collaboration Makes All the Difference Enabling New Virtual Care Models. I'm really excited to present with my colleague Matt Barr from Corewell Health. I'm Lizbeth Vitruba and I'm the Chief Clinical Officer at Avasure. I'm a third generation nurse. I've been in healthcare for more than 35 years. Most of my career has been in hospital settings. Until the last 8 years, I've been an industry nurse executive here at Avasure and really focused on virtual care models and continue to be a nurse. I will always be a nurse. Matt Barr is a clinical systems architect at Corewell Health. And as an architect, Matt advises leadership on strategic solutions with a primary focus on easing the burden of clinical staff and simplifying and enhancing the healthcare experience for the system's patients. Through telehealth platforms, clinical communications, applications and medical devices, Matt uses technology to solve some of today's most pressing healthcare problems. And he has to be comfortable talking to an IT engineer, a nurse, a C-level executive, and he's able to take a problem and help formulate the strategy that resonates with leadership. So we are going to, so as you see, this is a co-presentation from Avasure and Corewell Health. And on the next slide, we'll just kind of talk about the format for our webinar today. We're going to take a case study and compare and contrast a little bit the implementation at Corewell West of the virtual care model for patient safety, which was really happening in 2018 and into 2019 pre-COVID. And then about the current virtual care modeling for virtual nursing that is being worked on as, I would say, probably a more collaborative problem-solving approach. And so that'll be our theme. We'll use this case study to kind of talk through that theme of how IT and clinical can collaborate and how that really makes a difference.
Thanks, Lizbeth. So as you can see, there's Corewell Health might be a new name to several of you. Essentially, what it is a recent merger between Spectrum Health on the Western Michigan side, and in the Southeast was Beaumont Health. So a merger between the two organizations. As you can see here, there's some statistics showing the size and the breadth of a coverage of the healthcare system now. But there's two numbers that are kind of important in here that kind of keep in mind as we move forward through the presentation. First, of course, is the 22 hospital facilities that we have and where we care for patients, and the 15,000 nurses that are employed by Corewell Health. And as you know, that isn't enough. Even with 15,000, there's not nearly enough nurses. Next slide. So I won't belabor this too much, but I definitely wanted to give you kind of a look into the thought pattern of a clinical systems architect. One of my brilliant colleagues came up with this diagram, and really it's not necessarily to show the infrastructure of something, but it's more or less to start a conversation about the capabilities that IT needs to deliver to the clinical space and to the operations side of the house, and what those the interdependencies between those, the capabilities that are there, and then use that as a framework to talk about the strategy and how we get to particular solutions. And next slide. So zooming in a little bit on one corner of this to make it appropriate for this discussion that we're having, you can see that the virtual care models and capabilities are kind of tied in with the video platforms that we choose. And in 2017, 2018, and 2019, we were in the midst of trying to figure out what kind of solutions we can offer and what capabilities can we get. And so we look at all the different types of modalities, the different use cases for it, the capabilities both inside the walls of the hospital and outside, how that ties in with the lower acuity settings and safety, So those are kind of the discussions that we've had, and this kind of gives you an idea of what we were thinking about when we were going down the path of trying to find a solution for the safety, patient safety. And next slide.
Then meanwhile, over on the clinical side of the house, problem solving is approached in another way. So as clinicians, we tend to use more of a scientific method for problem solving. So very interesting that in 2018, 2019, the IT side had that mind map of their strategic ecosystem, technology ecosystem. Meanwhile, clinicians were encountering a problem and kind of walking it through the scientific method. And one example that I really like is the Iowa model for evidence-based practice, which I have here as an illustration. And that usually starts with a question and that frames the problem. So that's called a PICOS question, meaning there's the patient population for the P, the I is the intervention, the C is the control, and the O is the outcome that's being focused on. So the problem that they were looking at that time was for adult and pediatric inpatients, that's the P, is virtual monitoring, that's the intervention, superior to traditional one-to-one sitters, that would be the control, and the outcome for decreasing safety events such as falls and self-harm. So through the Iowa model and other similar, one of the first decision points, which is that diamond there, questions, is this a priority for the organization? And that could be answered with a resounding yes. So falls and adverse events in the acute care setting were increasing, and at the same time demand and need for that higher level of monitoring, which was the only traditional outcome or intervention is one-to-one sitters. So you have one staff member assigned to every single patient 24/7 that needs that level of monitoring. And so that was kind of the demand for that was going up. They're just unable to even meet that demand. So it was, yes, that is definitely a priority. And then the next diamond-shaped question is there sufficient clinical evidence? So that group would go through, as you would as a clinician, do a lit review, and they quickly found out that there is plenty a mountain of clinical evidence behind using video monitoring or telesitting for patient safety. So systematic reviews, years of evidence behind that. So that they felt comfortable with to move forward with the intervention. And then on the next slide, so that kind of puts it in these two, and we have sort of separate thought process here. So the clinical vetting process, there was urgency, there was a staffing challenge, there were patient safety challenges, the clinical evidence was more than sufficient, and then they checked and did their due diligence, checking on references of clinical peers in other hospitals to vet in this case it was the Avasure technology. And so they were ready with a solution, and so kind of brought it back to the IT. We had a problem, we found the solution. Here you go, Matt. Just do it.
And yeah, we get a lot of that actually in IT, where we get brought a solution after all of this work has been done and thought of, on the clinical side in a linear fashion, and then it's implement the solution. We have to go back and think about it from a little bit different perspective, right? Can we leverage a current platform that we have it for? Maybe clinical wasn't aware that we had a solution that did something similar. Can we scale this up, right? This has got to go across our entire enterprise. Does it work that way? What are the network requirements? Are we opening ourselves up to vulnerabilities? Are we going to saturate the network with video traffic? Are we going to do, what does that look like? And what does the vendor support model look like? Because typically, if a clinician has a problem, they're going to call the IT help desk, and then that gets routed. So what does that look like when we have to escalate up to the vendor? So those kinds of things are going through our mind from it. But we're starting at kind of at square one, and in preparation for this presentation, I already apologized to our director of nursing who had to live through this whole process of it, because it delayed the implementation of it by nearly an 18-month process from the starting of the business case up to until we actually went live. There was a significant delay in it because, frankly, we went back and said, well, cameras are a commodity. We can put a camera in there, so we brought in other vendors and things like that without really understanding all the research that had gone into the clinical side of it. So from approaching it this way caused significant delays and definitely was not the best experience for the clinical phase. Next slide. So happily for all of us, we did choose Avasure because that was the solution that was brought to us. And after all the due diligence, after going back over it, it truly was the solution that we needed to implement for this scenario. And as you can see, and I'll just briefly go over the architectural diagram, it solves the problems that that from an IT perspective, what we do. What is the network like? What is scalability? Can we fail over? As you can see from the architecture, we can fail over to different data centers. We have high availability, all those things that IT folks worry about that keep them up at night. We're able to satisfy those needs through this. Next slide. So this kind of gives you an idea of, and obviously there's been a lot of merger activity going on from Spectrum Health, Beaumont, and Lakeland Health, which are now considered our east for Beaumont, west for the Spectrum Health, Legacy Spectrum Health, and south for Lakeland. And each of those centers, each of those hospital units has their own hub where they monitor out to different patients, and various timelines through this the implementations took place, whereas Corwell West was the last to be implemented. But if I reference back to the architecture diagram that you saw earlier, you can see that we could easily consolidate all of these, the infrastructure in the back end, into a single platform and scale it up to what we need and centralize that. So from an IT perspective, that's a big win, because then you don't have to have as much, you don't have triplicate number of FTE to support it. You don't have to worry about the scalability. You can cover all of that in the single instance of the solution. Next slide.
So this is kind of my mental image of what the implementation looks like at Corwell Health System. And 2 slides ago, you saw the architectural design drawing, and this is kind of the more clinical view of the same thing. And as we were preparing for this webinar, I said to Matt, like, isn't there some kind of story that illustrates how people look at the same thing, but they have a different perspective and they see something completely different? And he said, you mean the parable of the blind man and the elephant? And so I looked that up, and there is a kind of a very ancient parable of blind men in front of an elephant, and they can only feel what's in front of them, and one's feeling the tusk, one's feeling a trunk, or one's feeling an ear, and they each think that they're looking at something completely different. They're not seeing the big picture. And I think that actually is an apt illustration of IT and clinical looking at this solution from their own perspectives. And the more we can take our blindfolds off and understand each other's perspectives, the smoother the implementation can go, and the more quickly you can get to outcomes. But from my perspective of my section, how I look clinically at the implementation is really at this human factor. So at the top left there are the monitoring staff attendants, and these aren't actual images from Corwell, but this is an illustration of how monitoring staff members are at a hub, and they're like lifeguards monitoring 12 to 16 patients each and keeping them safe really proactively and interacting with those patients. And those monitoring staff members are employees of the health system, and they are trained by the health system, and then they are working within their wireless infrastructure. And they're able to verbally redirect patients often as they're confused or forget where they are or starting to engage in something dangerous. They can proactively recognize that. I know we had one early implementation where an elderly woman with a hip fracture was just post-op, and she kind of forgot where she wasn't always clear where she was, and remembering that she wasn't at home and she was in the hospital and she needed to have assistance before getting up. And they still had a bed alarm on her as well as the monitoring staff. And she had a tray table, and she was kind of reaching over to get towards a tin of cookies, and her bed alarm went off, but the monitoring staff could see that she's doing what we call cookie grabbing behavior. Not as much risky behavior, so they could just say, how do they taste, and no reason to set an alarm in that situation. On the other hand, if monitoring staff see someone sitting on the edge of their bed and rocking and trying to get the momentum to stand up, or reaching for a walker that's a little too far out, away, that's when they would intervene, verbally redirect, or even use an alarm when necessary to have bedside staff come and rescue the patient. So that's kind of, if you're thinking about the maps and those 3 different hubs across Michigan, that's what it looks like on the top left-hand corner. Bottom left is how that looks in a patient room, and then the right-hand side is the pool that the lifeguards are watching to keep everyone safe at the same time. And within Corewell Health on the next slide, you can see some of the outcomes that they have gotten after implementation. And so this is recent data, 12 months rolling data from September of 21 to August of 22. And most of the patients were monitored for fall risk, and that is usually the primary reason for monitoring adults in the hospital environment. But then you'll see the second bullet down and the fourth bullet down, suicide risk and intentional self-harm. And those are the 2 top reasons for monitoring pediatric patients. And one of the big hospitals is Helen DeVos Children's Hospital. So this system is able to help some of those behavioral health risk patients and help keep them safe as they're on their journey through the emergency department in the hospital into the setting that they need as they continue on their journey for emotional and physical well-being. And I really like, although it's a smaller number, that the system is also used for staff safety. So some patients in emergency departments and elsewhere are volatile, impulsive, and the system can be used for staff safety as well. Just being a nurse myself for many years, I love that. That's one of the great reasons for monitoring patients and staff. And then they're able to also just think outside the box. So some of these other reasons are reasons for monitoring within the health system and during that year period of time, from eating disorders to smoking in patient rooms. And all of that happens, and there's a lot that happens in complexity that happens in patient rooms, and anything that can be done to help decrease disruption and also prevent adverse events and promote patient safety is wonderful, especially in these last couple of years. And then on the next slide too, so the outcomes that they were able to measure on the efficiency and financial side were substantial as well. So during that rolling 12 months of time across that whole map, there were 660,000 hours of telesitting that were provided to patients across the health system. So if you look on the left-hand side, if you had to staff all 660,000 hours with a one-to-one sitter, even at a rate of $16 an hour, which is kind of conservative. That's like no overtime, and that's never ever using agency or ever pulling someone from labor and delivery to help sit because they're having a little bit of quiet night up there. That happens. So that would have cost $10 million during that year, which probably wouldn't even been able to find that many of staff to keep that many patients safe, versus both the staff and all the cost of the technology. That same amount of monitoring was provided at $2.39 per hour. So with a total cost of $1.5 million. So if you see that efficiency and that lower cost that can be provided, then you also understand why the pain of the 18-month delay, and that, during that 18 months of decisions kind of being slowed down, those expenses and that pressure continues to occur on the health system. So then we're going to kind of switch gears. It was implemented in 2019, right, Matt? And then what happened?
So as we know, COVID happened, right? So, and it changed everything. And that's kind of an understatement. The urgency and this disease came upon us, and all of a sudden our census was skyrocketing. The acuity of the patients was increasing, and we had to solve these problems that were coming up quickly. And there was no time for an RFP. There was no time for this vetting of all these solutions and the debating the merits of it, right? And another thing that was crucial, I think, in building trust was that the clinical and IT leadership were shoved into a room, so both sometimes physically and virtually, in order to come up with solutions to a problem and understanding what that is, and then pretty much coming up with an action plan that could be executed by the IT or clinical staff, depending on who had to do what. And so this went throughout the pandemic, right? And we're hoping it's over, and that's we can, but then we can't rest on our laurels, right? So, but that relationship that was built there was very important. And in my case in particular, where I felt the urgency of this and felt some compassion for the staff, is in April of 2020. April of 2020, we had to send all the patient visitors home because of the acuity of the patients, and we had to shut down. That was an overnight decision. So what do we do to get those patients to be able to, so they're not so lonely, locked in their rooms, closed off? How do we get them to be able to visit their patients, or in the worst case, say goodbye? So in one of those, first experimental ways, we brought an iPad in on a stick, and I looked around, and it was a solution that I was trying to figure out if it would work. And I was the lucky one to go into a room, and it, putting all the PPE on, and then walking into the room of it, and not being familiar with that, being from the IT side, not really being in that situation before, it was quite stressful. And I have a lot of empathy for the nursing staff and the clinical folks who have to deal with this. They had to deal with this day in, day out thing. So I think a lot of individuals in IT got involved in these solutioning this way, and built relationships with their clinical counterparts. And I think that is carried on from throughout the organization and post the pandemic, so that there are things that we can work together on, and there's built up trust through this, right? Clinical started to understand that their IT counterparts weren't there just to say no, right? That we were there to help solution on this. So, and the last thing that came out of that was virtual became the norm, right? We know that ambulatory, it spiked way up because people weren't coming into the physician offices, but they started to think about it. How can we use this in the inpatient space, in the hospitals themselves? What's the best use of our technologies and the best use of our staff? So let's start thinking along those lines. Next slide, please.
So now there's a new problem to tackle. And that problem has to do with the staffing shortage, particularly the nursing staffing shortage. There are vacancies across the country, like Matt mentioned earlier. There are 15,000 nurses at Corewell, but not enough. Really, nobody has enough, and I don't think we will for many years. The turnover rate has jumped from, I believe it was about 18% of nurses in 2020 to 32% in 2021. And 52% of nurses are considering a change in their position. But not only is there a shortage of numbers, but there is an experience complexity gap as well. So as some of the more experienced nurses, they probably didn't want to abandon their colleagues in the middle of the war, but now they're fatigued and they're kind of ready to move on, and maybe even can't keep up with physical demands anymore. So what you're losing that brain trust of the more experienced nurses, while inexperienced nurses are coming in who didn't have as great of an experience in nursing school the last few years. Meanwhile, patients just continue to get more complex, physiologically complex as well as behaviorally complex, so that we have that experience complexity gap. So there's really no choice but to look at virtual care models where nurses' expertise can be supported at the bedside in a virtual way as well. So Corewell Health is kind of looking at that problem and that shortage and working together in parallel with their IT colleagues on ways to address it.
And so from the IT perspective, you know, there's still some constraints that we operate under, right? Similar to the quite a few slides ago where we had a similar, you know, layout here. But in this case, what we're doing is how can we leverage our current platforms, right? Versus bringing in something new, and the long lead time it takes to do that. Not only that, we're facing obviously financial headwinds, right, in healthcare, all over healthcare, because of this. The situation that we've been through, supplies and things like that, inflationary challenges, things like that. And secondarily, what are we doing from an integration with the EMR? How do we you know, keep the nurse in the chart, right? That's the UI that they're used to, and let's not make them fumble around from a different solution if they wanted to do something different with, you know, see a patient or whatever. So let's keep them integrated with that. You know, and throughout this, you know, as I mentioned on the last slide about COVID changing everything, let's leverage those clinical relationships that we built and that trust that we built across there, and start talking early to our clinical nurse specialists that really understand the space and understand what can we do. You know, with this work, with this start bringing them in on those conversations about how we could solve it with our technology, particular technology, and show that, you know, show the math. You know, this is why we think this would work. This is what this can cause a problem, you know, as we go back and forth on this. And you know, of course, and again, that, you know, that last bullet point emphasizes the financial headwinds that we're running into. We need to consolidate and centralize the monitoring of patients and the solutions that are run under the hood there, right, in our data centers and things like that, and not, you know, have multiple solutions doing the same thing.
So what we're really seeing bubble up at Avasure are two models of virtual nursing, and I think that they're illustrated on the next slide here. And they focus on, the one has been more prevalent before COVID, even an expert oversight nurse, and that nurse might be an ICU nurse monitoring a cohort of highly acute patients across the whole shift, and kind of getting inputs from physiologic monitoring, getting inputs from algorithms within the electronic health record, and keeping high acuity cohort of patients safe throughout their shift. But what is, I think, a little newer and more innovative is a clinical resource virtual nurse that's really focused where the big need right now is in the med surg setting with more novice nurses. higher turn, high turnover of patients, and that virtual nurse is able to help with documentation. 25% of what the bedside nurses do is documentation, and not all of that has to be done with hands-on. And a virtual nurse can do a really elegant admission or discharge process with patients that helps. It helps throughput, it helps kind of with bottlenecks, maybe holding in the ED, and frees up the bedside nurse at the same time. And anything that we're seeing with virtual nursing, there's an element of mentoring as well. I talked to a chief nurse a few weeks ago, and she said it really nicely. She said, I have some nurses that the spirit is willing, but the body is weak. And so she has nurses that maybe aren't able to do the 3 12-hour shifts anymore, but they love mentoring, they love teaching patients, and they're there and they can be there to support a bedside nurse. And I'll just mention one more illustration of that, where there was a novice nurse, and she was really kind of handling a high nurse to patient ratio, high acuity, and the virtual nurse was taking tasks, and I've got this, and I'll call that physician and let you know what the feedback was, and I can help finish up this discharge here. And the virtual nurse stopped and said, I just have a question for you. Am I doing a good job? And that virtual nurse was able to give her that emotional support as well. And so it can just be just a great collaboration between the virtual and the bedside care team.
And from a technology perspective, again, we're leveraging the platforms that we already have, and we're trying to, things like I've been brought in on conversations very early on, and how do we do this? What's the best, and how do we, I had those conversations with the offshore technology folks, and how do we integrate this with the EMR to make sure that we keep them in the chart, right? And then for the documentation, how do we make this as easy as possible? What does that look like? How do they move from patient to patient? Throughout those are all the things that on top of the normal IT stuff. It's the engagement early on with clinical staff and their ask and understanding their needs, engaging with the vendor, doing that translation of, well, this is what this really means, and this is how it would, and make it a better experience for the nurse. Those kind of things. Those are the conversations that we're having now about this.
Yeah, and I love how that's happening right now. Those bedside nurses were ready to just get going and kind of cobbled something together. And then when you and your team was able to come in and say, you don't have to do it that way, we can integrate and make it even a smoother workflow. So when they are doing a pilot, they're judging the actual outcomes and the actual interactions with the patients versus the pilot being skewed by clunky workflows or technology that isn't as integrated as it could be, now that you've got your IT colleagues helping support not just the solution, but working on the problem together. And then on the last slide, I think we just have some lessons learned and pull it all back together from that first implementation to the current one, and how does that come together?
So of course, we've been talking about, this was, obviously you probably came into this thinking it was just about one solution, one technology and things like that, but it's really about that collaboration between clinical and IT, and that should be the new normal, right? I mean, we're always going to have pockets of that, being surprised each other on ways we solve problems, but the earlier we get engaged, the better off we are. We need to build that trust through transparency. We know our processes can be convoluted and painful. They're painful for us too. So we tend to, if I can help, ease through a security review, or I can help translate what's going on from what they mean by this requirement or that requirement, and I can translate that and understand where some of the delay is, help folks understand what's going on in the supply chain space of why we can't get particular things. Those are the kinds of things that IT can take the lead in to help help smooth this transition to this new normal that we're going to be going through. And this should be the norm, that collaboration, that early engagement. Use those relationships you have. If a VP of a particular, a clinical line is not going to talk to a lowly architect like me, but find that person that they trust, right? And who do they trust? And if I can get their time and talk to them and understand what's top of mind for them, and then I can start thinking about these things before it becomes a bring me a solution, bring me the problem, and we can engage in an open dialogue and start talking about this and how do we solve that problem together. I think that's the key to take away from here.
Yeah, and just working together with you, Matt, on pulling this presentation together, and others that I've worked with who sit in your type of role, it's much more satisfying and to support the bedside nurse. And I know from your heart that's what gets you out of bed in the morning, is really helping to make the bedside process smoother, and that has to be done in order for patients to have a good experience. So it really starts with supporting bedside clinicians in order to get automatically from that good patient outcomes. So thank you so much for taking the time to work on this with us, and for all that you do for the patients and clinicians at Corewell Health.
It's been my pleasure, and I mean that. It really has.
Thanks, Matt.